Welcome to today's webinar, a part of PYA's commitment to lifelong learning and thought leadership. We understand the importance of clear, relevant, timely information in the industries we serve, so PYA offers a wide variety of webinars, white papers, articles, checklists, and other tools. Subscribe to our newsletters, follow us on social media, and check out our PYA webinar recast series wherever you listen to podcasts. You can find all this and previous webinars for free at pyapc.com. For today's webinar, you may submit questions through the control panel. Also, you can find a copy of the slides in the handouts pane. After the webinar, you will receive an email with a copy of the slides and a recording of this webinar session. Please stay on the line after the webinar to complete a short survey and post any questions you may have. Thank you so much for joining us. Here are today's presenters.
Hello, welcome to PYA's latest webinar series, Revenue Recharge. You can't cut your way to success. My name is Kristen Davidson, and I'm joined today with my colleague, Sarah Bowman. Sarah and I are both principals supporting PYA's revenue and compliance advisory services. And we'll take just a moment to introduce ourselves, and then we'll quickly jump into our topic today. Personally, I've been in healthcare over 25 years, beginning my career in a large healthcare system within the revenue cycle and ultimately corporate HR before transitioning to consulting about 12 years ago. At PYA, I primarily focus on compliance program effectiveness and risk assessments, as well as leading teams to perform operational improvement assessments, including within transaction due diligence. And related, I also support our integration advisory services and assist clients post-close with their integration efforts. Sarah?
Thanks, Kristen. I am entering my 18th year in healthcare. I started in HIM, or kind of the middle part of the revenue cycle. I've also worked in a corporate revenue cycle program management prior to my consulting life. So I've been with the firm over 10 years. So the majority of my career has been spent in consulting. And within PYA, I work with our revenue and compliance practice area, assisting clients with all sorts of matters related to 340B, coding and documentation, including overpayment analyses, black box reimbursement, and various managed care contracting and modeling activities. And I apologize for my voice today. I'm a little bit hoarse, but we'll get through it. I'm really excited to be presenting, or co-presenting rather, with Kristen. So this will be great.
Awesome. Thanks, Sarah. So again, we are delighted to kick off Revenue Recharge with the first episode in a series of 6 to share ways that providers, including hospital systems and physician practices, can identify revenue opportunities. So in this specific episode, Sarah and I are going to focus on the front and middle revenue cycle improvement opportunity areas. We're going to share some best practices related to operational assessments and the importance of evaluating your charge description master, which will be the last time you hear me say that. I will refer to it as a CDM from now on. Fee schedules, as well as looking at just importance of ongoing auditing and monitoring, and the impact that it can have on reimbursement with downstream denials. So the good news is that none of what we're going to share is new news. And if you don't have 30 minutes today and you only have 3, we're giving you the answers up front, or really rather the 5 questions that you need to be asking in your organization. So the first, number 1, is people. Is my registration staff educated on our policies, and are they confident in themselves and empowered by leadership to request due payment? Number 2, is eligibility verified, and is required prior authorization obtained in advance of the appointment or procedure? Number 3, what is our point of services collection rate? Number 4, is charge capture reconciliation performed, especially to confirm capture of outside charges for in those physician practices for providers that perform services outside the walls of their practice? And are we monitoring for accurate code assignment? And number 5, speaking of charges, when was the last time our CDM was updated? So whether you're in a hospital setting or in a physician practice setting, ask these 5 questions and you will be on your way to determining if your revenue needs a recharge. So I'm going to jump right in with number one, people. And this is an area that oftentimes people, i.e. leadership, forget about sometimes. So when we're discussing improvement opportunities, you often hear the reference to people, process, and technology. And the same holds true for our discussion today. The first key component to improved revenue capture actually begins with your people, and specifically your registration staff or your upfront receptionist in your physician practice. And that's followed closely by your financial counselors. So you can teach the registration staff the process, you can show them how to use the technology, but capitalizing on the registration experience through that thorough training and education is really the critical piece to success at this preliminary stage of the revenue cycle. Not to mention, it has a really strong impact on your patient's experience. So your registration staff are usually the first interaction that a patient has with your hospital or your practice. And so it is their first impression. And so with this, thorough training, the staff and the financial counselors, we don't want to forget about them, they can be empowered and they can be confident to have these potentially difficult conversations, but it's about expected payments. These payments are expected. These payments are not a surprise. And so they're expected payments, and they can have these conversations in that professional and helpful manner to patients. A key metric associated with well-trained staff up front is that communication of the expected time of service or that upfront collection rate, as well as any other current or past due balances. Oftentimes, when we're doing assessments, we find that the staff may be a little timid or a little hesitant to inquire about payment, but they have to. It's expected payment. It's based on their payer contract. So patients are usually aware that they owe an upfront collection at time of service, and they're aware that they're going to receive a bill for services performed after their visit, perhaps in a hospital or practice or wherever it may be. And so having that well-trained staff is really a critical part of establishing that good first impression to the patients overall and empowering that staff for them to be confident to ask for that expected payment. So now moving right along to number two, eligibility and verification and registration. So if you think of revenue cycle like a factory line, it starts at the very beginning with pre-registration or registration admissions, and then you go through that middle part of your code assignment and your charge capture and reconciliation, and then you have that back end. And so the more accurate information that's collected during that pre-registration part, it's easier to submit clean claims if the information's correct to begin with. So you have the insurance card, you're confirming the patient's correct demographic information, you're confirming the patient's correct payer information, and all of that leads through that factory line in that revenue cycle to get a clean claim out the door and to capitalize on your reimbursement. So capturing that information on the front end is really critical to releasing that clean claim on the back end. And that inaccurate information, it can lead to higher denial rates, and it really can put claims on hold. And so your staff trying to swim upstream, so to speak, and clarify information or capture information after the fact really does delay the claim getting out the door. With that, ensuring eligibility is performed timely and prior to the appointment is key. For your physician practices, this should obviously be done prior to the appointment being scheduled, 2 to 3 days in advance, particularly at year end. You want to double check that eligibility as the year ends and new contracts, new insurance coverage starts at the beginning of January. And if you're in the hospital setting, you want to try to pre-register patients as much as possible. Both of these allow time to resolve any demographic or insurance verification issues prior to seeing the patient. And so again, as we go back to that patient experience, having this taken care of and confirmed in advance proves for a smoother patient experience upon arrival. And another vital key to reimbursement is a sound prior authorization process being in place. Your scheduling processes, they should support adequate time to obtain the prior authorization. Sometimes this can be a challenge with physicians who are anxious to serve their patients and want to push through those procedures or those scheduled tests without obtaining that prior authorization in advance. But it's really important that your timeline and your processes within your practice, as well as within the hospital, allow for that time to ensure that that prior authorization is obtained, because that's what ensures your appropriate payment on the back end, as well as understanding the appropriate patient financial responsibility. And that way, you know what to collect at the time the patient arrives, or on the back end when you're sending a patient a statement for their responsibility. In urgent cases, there are those times that there are urgent cases and that the procedure or the test needs to be performed more quickly than what the prior authorization can be obtained. That happens, but have a process in place to be able to handle those urgent cases and to be able to accommodate that expedited timeline along the way. And then finally, related to this topic, communicate to your patients what their expected financial responsibility is going to be. Again, we go back to where we started with, it's communication of due payment, and having good staff and financial counselors that are well trained and competent and confident to be able to communicate this information. It's really important to communicate to patients what their expected patient financial responsibility is going to be. And then second to that, it's even more important to actually collect it upon arrival of that patient. So with that, it's a perfect segue into our third topic that Sarah will cover, which is point of service collections.
Perfect. Thanks, Kristen. So Kristen talked about how our 5 points today are really inclusive of care settings. So whether you're talking about an inpatient hospital, outpatient, hospital services, a physician clinic, perhaps some other kind of ancillary care setting like an urgent care, these are all, these can be applied to really any of those settings or tweaked, so to speak, for any of those settings. And so when we think about revenue, we think about reimbursement, really starting at the beginning or even before the patient is seen for their care, making sure that these processes are in place. We know that the people that are responsible for doing a lot of these things oftentimes are in high stress roles. There can be a lot of turnover, unfortunately, in individuals that are working at the front desk or individuals that are working within registration. And so that's where making sure that you guys as organizations have really well-defined policies and procedures and processes and are continually doing that education and training and retraining. If you can identify some super users or some folks that are really, really good at these processes to kind of help guide the rest of the team, that can be really impactful and really helpful as well. So our number 3 item is point of service collections. And so we are, it's high deductible health plans have become kind of the norm for better or worse. So we've all seen them. They've been around for quite some time now. Even some of the deductibles on PPO health plans have become a lot higher than they used to be even 3, 5, 7 years ago. And so because of those continuing to kind of take over the market, and for a lot of providers and a lot of healthcare organizations, those make up a big bulk of their commercial business. And so it's really important that that point of service collections process be ironclad, make it as tight as you possibly can. We know that good scripting and good staff education can help make this feel more doable and less burdensome, even to individuals that really, aren't fans of asking patients for payment up front. Some people handle it, better and more easily than others, but we know that doing this effectively on the front end really can help both improve collections and then decrease the administrative costs and burden associated with trying to get patients to pay after the fact. And so the manner in which staff are being taught to ask for that is really, really important, because something so simple as changing your language, changing the ask a little bit can really increase the likelihood of success and even impact the patient experience overall, right? And how that person is asking for that payment, because they are The registration personnel and the people that are working at the front desk in these care settings, they are oftentimes the patient's kind of first interaction with that provider or with that health system. So if we think about upfront collections, point of service collections in terms of kind of easiest to hardest or easiest to potentially most challenging, the lowest hanging fruit, as Kristen mentioned, would be kind of associated with those scheduled visits. So we know the patient's coming, we know the patient's coming on this day and time for their appointment, and so that allows staff the gift of time. It allows them time to do that insurance verification process that Kristen mentioned, estimate what the patient responsibility is going to be, run any checks or rechecks, call the patient perhaps, Mrs. Bowman, it looks like your insurance has changed. Cigna's no longer showing as your insurance. Did you have a change? Instead of having to do that when the patient arrives for their appointment, before the patient is standing in front of them. And so having that process from a workflow perspective then sets the stage for point of service collections as well. So anything that's being done from a physician clinic perspective, outpatient ancillary testing that might be done in a hospital setting, or other outpatient, like one-day surgery services or procedural services, those should be kind of your first priority when you're thinking about areas for refinement, doing a refresh on staff education, maybe revamping some of your processes, and then also your scripting, your collection scripting. And so there's all sorts of research and studies out there on how you ask the question and how effective that can be. And so a simple tweak in how the ask is made can be impactful, as I mentioned, again, to the patient experience, but also to the likelihood of success. So it might be going from, Mrs. Bowman, would you like to pay today, to how much are you able to pay today? It's really easy to say, no, I wouldn't, I can't pay today. I don't want to pay today. My wallet's in the car, that my car is parked far away. All of those things that we've kind of all heard, versus how much are you able to pay today kind of takes away the yes, no as an option. Others have had success with statements, rather than questions. So, Mrs. Bowman, your patient responsible portion today is estimated at $50. How would you like to pay today? We accept cash, check, and all major credit cards. That again is a little different than, Mrs. Bowman, would you like to pay your patient responsible portion today at $50? Now it's easy for me to say, no, I don't want to pay that today. And so sometimes those little tweaks can be really helpful. And it also can sometimes give some confidence to the staff members as, hey, this is really important for the organization. This is part of the patient's care, is that we receive payment for the services and the good care that we're going to give the patient. It's not a bad thing that we're asking for this, and that we're trying to get this. It's no different than going to a restaurant. You expect to have to pay for your food, so it's really no different. Kind of helping to run that home for folks. I'll talk in just a minute about how that has to shift a little bit when we talk about other care settings within the hospital when visits are not scheduled. But one other point before I move on to that, we know that for some teams, for some departments, for some groups, gamifying this can help. It can help enhance the staff's perception of what they're being asked to do. It can help improve outcomes as well. So, make it a contest across your team. Again, everybody kind of playing by the same rules, playing by the same process, the same scripting, but saying, hey, gosh, let's see for the month of March, who can get the most upfront collections based on what's due, or tracking that to see, gosh, Kristen always does a fantastic job with her point of service collections week after week or month after month. Kristen, can you kind of do a little bit of a lunch and learn in service for the rest of our team? How are you able to be so successful with that? And so allowing that kind of peer mentoring to occur, or a train the trainer type of approach, has also been really successful for a number of our clients. And so that is all, sort of good and perhaps a little bit easier when, We know the patient's coming, we know what they're going to be seen for, we've been able to verify their insurance benefits and figure out what their patient responsible portion is, perhaps a few days before they even show up at our facility for care. And so that's all fine and well. But another area that oftentimes gets challenged and can become very difficult for providers is related to hospital services, inpatient hospital services, emergency department hospital services, ED services in particular are challenging because patients present at all hours of the day and night. They may or may not have, anything with them. They really might not have their wallet with them. They may have been brought in by ambulance. A family member or a friend might have brought them. They're generally oftentimes having a pretty stressful go. They may be in a lot of pain. They may be very scared. And so thinking about really what the patient experience and what the patient is going through, and thinking through how can we educate our staff to make sure that we're being compassionate and we're holding true to our organization's core values in the timing and the method and the manner in which we ask for those point of service collections are really, really important. And so first and foremost, obviously, make sure that the patient has been cared for, make sure that they've been triaged appropriately, they've been seen by a provider. A lot of clients have success with setting up that point of service collection process toward the end of that patient's visit in the ED, close to the time that they are going to be discharged. If we know that they're going to be discharged and not admitted for observation, for example. So anything that you're able to chat with them about, Mrs. Bowman, we've checked your benefits and it looks like you have a $500 copay for your ER visit. How would you like to take care of that today? That communication and that dialogue with the patient, even if the result is that the patient gets set up on a payment plan or something to that effect, you're still shortening that window for payment versus waiting until the patient is discharged from their visit, sent home. We send them a statement. They have to hopefully follow up with us and let us know that they want to get set up on a payment plan or something of that nature. And so again, the goal here being improving revenue, decreasing your cost to collect, while also staying true to your organization's core values, making sure you've got a strong patient experience, making sure that the staff feel comfortable and confident having those conversations. Really, it does shift a bit when you're in some of those higher acuity levels of care than it does, again, when you've got that luxury of time. We know that Sarah Bowman's gonna be presenting and she's gonna be coming in for her sore throat, where she's a little bit hoarse and what have you. That's different than when she shows up, at 1 o'clock in the morning on a Saturday morning and perhaps there's a broken arm or whatever has gone on. So really, making sure that you're setting those expectations with the team, with the staff, is really, really important. And so talking about point of service collections kind of leads us into our next topic, which is talking about our CDM or our fee schedule and making sure that we're reviewing that information really on a regular basis. So occasionally in our work, we will hear from clients, sometimes in a revenue cycle review, sometimes in a due diligence, kind of ops due diligence, rev cycle due diligence review. Gosh, we haven't changed our charges in years, or we haven't really looked at our fees in a while. Or my personal favorite is, oh, we get paid everything that we charge. So if we charge $100, we get $100 back. Blue Cross, they give us all of our charges now, which might seem great in other kind of types of business, but in healthcare, that's not a good thing actually, and oftentimes can mean that enough time has passed that your payer contracts have surpassed your fee schedule. And you really don't ever want that to happen. So on an annual basis, we would like organizations to be assessing what are your charges? What are your charges across all services? Inpatient, outpatient, if you've got a surgery center, professional services as well for those that are doing professional billing. And not looking at that can really result in money being left on the table. Given the nature of commercial payer contracts, they're typically quite sophisticated. They will have lesser of language in their agreements, which basically state that they're going to pay you, the provider, the lower of either their negotiated contract rate or what the provider chooses to charge. And so when we hear that, gosh, we're charging $100 for this service and we're always getting $100 in payment from the payer, that typically means that lesser of language is being triggered there, and along the way some updates that should have happened to the fee schedule or to the charge master may not have happened. Payers are really sophisticated these days with their modeling and with their contract language. So at a minimum, review those charges, but also look at what your contract language is for some of your heavy hitting top commercial payers, because some of them may have language that limits the amount that you can increase your charges in a specific year, or specific 12-month rolling time period, or something to that effect. So keep that in mind as well, because that can have negative repercussions from the way that those claims are adjudicated and paid. And then, of course, we can't do anything in a vacuum in healthcare. Everything is kind of interrelated, and setting charges, again, is no exception to that. So for health systems in particular, for hospital services, because of where we are today with price transparency, the environment that we're in there, in addition to, gosh, where are our charges? Do we need to increase our charges? Where are we sitting today? And looking at your payer contracts in relation to that, you also want to look at, gosh, where do we sit as compared to our peers in the market? Be sure to know kind of where you fall in the market and have some sensitivity there for shoppable services. Every market really has some similarities and differences. We work with clients all across the country. Even in Alaska and Hawaii, we've got clients in all 50 states. And so every market is different and has unique factors to it. And so as the providers in those communities, you're best versed in what those uniquenesses are. Maybe that you're able to be more aggressive in your charge, in your rate setting for charges in some services, whereas in others, you've got to be more competitive. And so you might be keeping your charges lower for that reason. And that might make sense from a strategy perspective for the organization. We see that oftentimes happen in markets where there are a lot of surgery centers, independent surgery centers that are doing outpatient procedures. If the hospital's trying to compete for some of that business, either with their own ASC or with just their outpatient hospital surgery services, the strategy there for their charge setting might be different than it is for other outpatient services. So taking a look at that full picture is really, really important. We're going to have a whole session within our revenue recharge series. We have a session that will be coming up later this spring on managed care contracting considerations. So if that's something of interest to you, if you're hearing me talk about this and going, oh my gosh, I don't know where to start, we've got a lot of questions or we need a lot of help in that area, please make sure that you tune in and join us for that session as well. So with that, I think, Kristen, you're going to talk about our fifth and final item related to charge capture and co-assignment.
Thanks, Sarah. And you're right. Number 5 is charge capture and code assignment. Similar to what Sarah just talked about as relates to the CDM, obviously more geared toward the hospital setting. And when I talk about charge capture and code assignment, I'm going to talk a little bit more focused on the physician practice setting, because this is an opportunity that we identify actually a lot when we're doing our operational assessments, particularly within due diligence, and that is reconciliation of charge capture. Within the office setting, I don't really find a lot of issues there. Fortunately, the EMRs and practice management systems are really advanced these days, which is very helpful. But what I do find is there's still opportunity to ensure that those charges are captured for professional services performed outside of the physician office practice. So what do I mean by that? I mean, for example, your orthopedics or your cardiologists that are performing tests or procedures in a hospital or in an ambulatory surgery center, for example, it's important that those charges are captured. In addition to that, on a side note, it's also important that the medical record documentation that is captured within those facilities is transferred back to that physician practice record. Because if you're ever audited in the future, you have to provide that medical record documentation to justify the codes assigned to the claim that are paid for. And what I was recently told by an individual was, well, that's the hospital's responsibility where I did the procedure in the operating room. Well, the hospital does have their own responsibility related to the facility services, but for those professional fee services that are charged, it's the physician's responsibility or their practice to ensure that that OR report, that medical record documentation, makes it back to the physician practice record, or at minimum, the physician practice staff have access. Say most of the time they're interfaced maybe with a hospital EMR system, and they can quickly gather that information if they're ever audited in the future for a coding audit or payer audit or whatever the case may be. But capturing those outside charges, they're the old school ways of physicians grabbing a face sheet and documenting on a face sheet, a prescription pad. Those are still in practice today. Some of the more advanced ways of capturing those charges are through the EMR systems that they have. Some offer apps that will have a feature to be able to capture that charge while the physician's rounding or having just completed that procedure. There are also standalone apps that can interface to the EMR and practice management system to be able to capture those. So I really encourage you, particularly if you have a high volume of providers that practice and perform outside of the walls of your physician practice, to ensure that there are good processes in place to capture those outside facility charges. And with that, that leads us into coding education at minimum for providers if they're selecting their own code assignments, and for coders. And within that physician practice setting, your billers as well, because oftentimes the physician practices will only have billers versus certified coders. So it's important that that coding education is happening annually to capture new E&M guidelines that came out recently, understanding new regs around incident to and split shared documentation. And finally, ensuring that you have a strong coding audit compliance work plan in place, ensuring that that work plan includes new services that perhaps you're offering in your practice, and ensuring compliance with any new guidelines. Like I mentioned, the E&M guidelines and the split shared guidelines. So having those ongoing coding audits is important, and it ensures that you are promoting accurate code assignment, and you're establishing good processes to ensure that all the dollars are appropriately captured for your organization. So with that, we have concluded episode 1 of Revenue Recharge. Thank you for joining us. We hope you'll join us again for episode 2 of Revenue Recharge, which will be the back end of the revenue cycle on March 28th.
Thank you so much to today's presenters. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. You will soon receive an email with the contact information of the presenters and a recording of the webinar. Also, the slides and recordings for every PYA webinar are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about our full range of services. On behalf of PYA, thank you for joining us and have a great rest of your day.